Okay, so this is going to be part 2 of the urinary system recordings. And we're going to talk about renal physiology now. This will be broken up into several recordings. So glomerular filtration, this is the initial process of the nephrons to filter the blood. The glomerular capillary membranes filter the blood selectively based on size. These are fenestrated capillaries. Cells and large proteins cannot be filtered or should not be filtered, and they actually remain in the circulating blood. Smaller substances such as water, electrolytes, which would be sodium and potassium ions, acids and bases, hydrogen and bicarbonate ions, organic molecules, and metabolic waste will exit the blood to enter the capsular space as filtrate, or what we refer to as tubular fluid. Tubular reabsorption, this is a process in which the filtrate is modified as it flows through the tubules by removing substances. You are reclaiming or reabsorbing substances such as water, glucose, amino acids, and electrolytes from the tubular fluid to return them to the circulating blood is priority of this particular of tubular reabsorption. The nephron is able to reabsorb a majority of filtered water and solutes from the proximal tubule and the nephron loop. Reabsorption in the distal tubule and collecting duct is more precise. The nephron varies the amounts of different substances reabsorbed to maintain homeostasis as needs of the body change. The third phase is tubular secretion. This is when substances are added back into the filtrate from the peritoneal capillaries from excretion from the body. This may occur along the entire tubule, but some substances are secreted more from one region than the other. This helps to maintain electrolyte and acid-base homeostasis. It can also help to remove toxins from the blood that did not enter the tubular fluid through the filtration process. So again, there's 3 main events that occur at the nephron. The first is the formation of filtrate, which is glomerular filtration. The second is tubular reabsorption, where your fluid and solids are reabsorbed from the filtrate and returned back to the blood. And the second is tubular secretion, where substances are secreted from the blood back into the filtrate. And you can see where these processes occur in the direction that they're moving, either from the capillaries or from the tubules, in the figure right here. So we're going to look at these 3 different processes, and I'm going to break each one up into a recording. The first recording will be glomerular filtration. So the filtration membrane consists of 3 layers, collectively creates a barrier. This includes the fenestrated glomerular capillary endothelial cells, its basement or basal lamina, and then the podocytes. So the fenestrated glomerular capillary endothelial cells, these make up the deepest layer of the filtration barrier. As we've talked about with the cardiovascular system and the blood vessels, fenestrations are large pores between the endothelial cells. This makes them very leaky, allowing for more solids to readily just pass through. Now, the pore actually measures between 70 and 100 nanometers. That's 1/1000th of a meter. Still prevents large substances like blood cells, platelets, and large proteins from being able to exit the capillary blood flow. Now, the basement membrane, this is a thin layer of extracellular matrix gel. This makes up the second layer that separates the glomerular endothelial cells from the podocytes. Collagen fibers form a meshwork that acts like a sieve to prevent substances greater than 8 nanometers in diameter from entering into the capsular space. This blocks entry of most plasma membrane proteins. Negatively charged collagen fibers also will repel negatively charged plasma proteins, regardless of their size. The visceral layer of the glomerular capsule, which is the podocytes, will make up the final barrier before filtered substances become filtrate within that capsular space. It's the finest sieve of the three layers. It only allows substances smaller than 6 to 7 nanometers to pass into the capsular space. The pedicles, which are finger-like extensions of the podocytes, form what are called filtration slits by wrapping themselves around the glomerular capillary endothelial cells. Albumin, which is a protein that's found in the blood that reaches this thin layer, is effectively preventing from entering into the capsular space. So here we can see the glomerulus, and we can see, if we look at our layers here, okay, you can see how you have the endothelial layer, the basal lamina, and then you have the, finally, the podocyte layer here. So the pore size will determine the composition of fluid and solids that pass into the capsular space as filtrate. Water and small dissolved solids such as glucose, amino acids, and very small proteins pass through the filtration membrane pretty easily. Nitrogenous waste, which are groups of small substances that can be readily filtered, include urea and ammonia ions from the protein metabolism, creatinine, which is produced by an enzyme creatine kinase in muscle, as well as uric acid, which is a product of nucleic acid metabolism. The filtration fraction is the percentage of plasma that becomes filtrate in the capsular space. On average, it's about 20%, or 1/5 of the plasma that enters into the glomerulus becomes filtrate. The looping structure of the glomerular capillaries, if you notice, it was like a tuft that was just capillaries wrapped around itself, increases their surface area, allowing for a large filtration fraction. The combined surface area of the filtration membranes of both kidneys is about 6 meters squared, which is about the size of a small bedroom. The amount of filtrate that's formed by both kidneys in 1 minute is referred to as something called the glomerular filtration rate, or GFR. You guys may have heard of that term before. On average, it's about 125 mils per minute, or the equivalent of filtering all 3 liters of blood plasma about 60 times per day. Two forces that generate the filtration pressures that drive the fluid movement in a typical capillary bed include that of hydrostatic pressure, which is the blood pressure, as well as colloid osmotic pressure. Remember, the osmotic pressure is the pressure that's going to force fluid into the blood vessel because of all the proteins and solids that are present in the blood. So the hydrostatic pressure, again, is your blood pressure. This is the force of fluid on the capillary walls. It pushes water out of the capillary into the interstitial space. The colloid osmotic pressure, this is the pressure created by the proteins, mostly albumin, in plasma. This creates an osmotic gradient that pulls water back into the capillaries by osmosis. So these two pressures are actually opposing forces. Now, ideally, within the capillary bed of the glomerulus, you're going to want this to be higher on the hydrostatic pressure end so that you can force this fluid out. The interaction between these two pressures determines your net filtration pressure, the direction that the water will flow. Water moves out when the hydrostatic pressure is higher than that of the colloid osmotic pressure. Water moves into the capillary when the colloid osmotic pressure is higher than that of hydrostatic pressure. So the net filtration of the glomerulus is determined by three driving forces. The glomerular hydrostatic pressure, which is determined mostly by systemic blood pressure. It's about 50. Higher than average capillary beds, the hydrostatic pressure that you typically see in a capillary is somewhere between 17 and 35. But this higher pressure actually favors filtration of substances through the filtration membrane into the actual capsular space. You then have what we call the glomerular colloid osmotic pressure. This is similar to the colloid osmotic pressure. It's created mostly by albumin, only slightly higher than typical capillary bed. It's about 30. Now this is actually going to oppose the glomerular hydrostatic pressure. You then have what's referred to as the capsular hydrostatic pressure. Because you have filtrate and fluid that's collecting within the capsule, that is actually a pressure that's working on, in the opposite direction towards the capillary. And this particular pressure will oppose filtration. So your net filtration pressure is the glomerular hydrostatic pressure minus the osmotic pressure plus the capsular hydrostatic pressure. The net filtration pressure favors filtration, as your glomerular hydrostatic pressure should always be greater than the sum of the forces that oppose filtration. So here, if you want to visualize this, we have the glomerular hydrostatic pressure in the blood vessel that's at 50. Remember that you have the albumin, which is going to create the glomerular colloid osmotic pressure, which is 30. So that's an opposing force in this direction. So now our net difference is 50 minus 30, which is 20. You also have some pressure because there's filtrate on this side of the membrane, and that's referred to as the capsular hydrostatic pressure, and that is 10. So now 20 minus 10 gives you a net difference of 10, still in an outward motion. So the net filtration pressure will be 10, and that will allow fluid to leave from the blood vessel to the capsular space. Remember, fluids move by pressure, higher to lower, okay? If your blood pressure is too low, you're not going to be able to generate filtrate and form filtrate. So factors that can affect the glomerular filtration rate. Autoregulation, you have internal kidney mechanisms that work together to maintain the GFR within a normal range. We have what's referred to as the myogenic mechanism. This is similar to the construction of smooth muscle in the blood vessel walls in response to an increase in blood pressure. So an increase in systemic blood pressure stretches the afferent arteriole, increasing the GFR. This triggers smooth muscle constriction of the afferent arterioles, reducing blood flow through the glomerulus and returning the GFR back to normal. If you have a decreased systemic blood pressure, stretching the afferent arterioles less, this will cause a reduction in the GFR and triggers smooth muscle relaxation, increasing blood flow through the glomerulus, causing increases in the GFR back towards the normal range. This particular mechanism, the myogenic mechanism, works best for systemic blood pressure changes between 80 and 180, and being able to restore the GFR back to normal within that range. You then have what's referred to as tubuloglomerular feedback. This is a second mechanism. It involves the macula densa of the distal renal tubules. It is a negative feedback loop that controls the pressure in the glomerulus in response to sodium chloride concentration in the filtrate. As your GFR increases, the volume of filtrate flowing through the renal tubule increases. and the more sodium and chloride ions are absorbed into the macula densa cells. The macula densa responds to increases in sodium chloride concentrations by releasing chemicals that cause the afferent arterioles to constrict. The macula densa will also signal to JG cells, causing a reduction in the release of hormones, renin and angiotensin II. This allows the afferent arterioles to dilate, causing a decrease in the GFR towards normal. Decreases in the GFR reduces the sodium and chloride ions absorbed by the macula densa, and this triggers dilation of the afferent arteriole and constriction of the efferent arteriole, increasing the glomerular hydrostatic pressure to restore your GFR. Now, the hormonal effects on GFR are part of a larger system that involves regulation of systemic blood pressure. And this includes the angiotensin II and natriuretic peptides. We talked about these with the cardiovascular system there. We have the Rast system, which is the renin, angiotensin, aldosterone system. This complex system that maintains systemic blood pressure primarily and GFR secondarily responds to a combination of three conditions: stimulation by the sympathetic nervous system, low glomerular hydrostatic pressure, and stimulation from the macula densa. So the Rast system, when blood pressure drops, so does the GFR. Reduction in blood flow through the afferent arterioles triggers those JG cells to release renin. That renin gets released into the bloodstream, and then renin will then convert angiotensinogen into angiotensin I. This can be further converted into a more active form referred to as angiotensin II by angiotensin converting enzyme, or ACE, which is produced by the endothelial cells in the lungs. Now, what is angiotensin II going to do? We kind of talked about this blood pressure regulation. It's going to cause vasoconstriction of the afferent arterioles and systemic blood vessels. You will also get reabsorption of sodium ions, chloride ions, and water from the proximal tubule. By reabsorbing these various ions, you will also bring along with you more water. Aldosterone release will further promote the sodium and water reabsorption, and then you will also increase your thirst signals. All of these factors will increase systemic blood pressure and subsequently the GFR. So here you can see systemic blood pressure decreases, your GFR decreases. This causes renin to be released. And renin will activate angiotensinogen into angiotensin I. Angiotensin I gets activated into angiotensin II. And again, this will promote vasoconstriction of your efferent arterioles, provides vasoconstriction of the systemic blood vessels, promotes the reabsorption of sodium and chloride by the proximal tubules, and then also promotes the release of aldosterone, which will sort of continue all of those effects. Now, the heart can also release a hormone referred to as atrial natriuretic peptide. And this is in response to increasing fluid volume. ANP will lower blood volume and therefore blood pressure to reduce the workload on the heart. ANP increases the GFR by dilating the afferent arterioles and constricting the efferent arterioles. This increases the glomerular hydrostatic pressure. High GFR leads to blood volume reduction by favoring fluid loss from the kidneys, and this will reduce your systemic blood pressure. You also can have neuroregulation of the GFR, primarily involving the sympathetic division of the autonomic nervous system and its hormone norepinephrine, as it works with the larger system to control systemic blood pressure. Increased sympathetic activity causes vasoconstriction of the afferent arterioles like most systemic blood vessels. Increases in systemic blood pressure affect the GFR, depends on the levels of stimulation. Low levels of sympathetic stimulation will trigger the JG cells to release renin, and then you know what happens from there on in. You're going to increase your blood pressure and increase your GFR. High levels of sympathetic stimulation leads to high levels of angiotensin II, constricts both afferent and efferent arterioles, decreasing GFR to minimize fluid loss, preserve blood volume, and maintain blood pressure. So think about how arterial diameter can influence the GFR. Vasoconstriction of the afferent arteriole turns down the faucet, allows less blood flow into the glomerulus, and that will actually decrease your overall GFR. Vasoconstriction on the efferent arterioles clogs the drain, causing blood to back up within the glomerulus, increasing your glomerular hydrostatic pressure and increasing your GFR. So this is how you can sort of regulate these at both ends. And that's shown here. Okay, and this is a nice little table because this will actually help you to summarize all of the regulatory mechanisms that surround glomerular filtration rate, or GFR. Now, if your GFR decreases, the kidneys may be unable to carry out their vital functions, and this is called renal failure. Renal failure may be a short-term condition, which is more commonly referred to as acute renal failure or acute kidney injury. And this resolves with treatment. Renal failure may become a chronic issue after 3 or more months of decreased GFR. And this is commonly seen with long-standing diabetes and hypertension. Uremia, this is a condition that can develop when the GFR is less than 50% that of normal. This leads to a buildup of waste products, fluid, electrolytes, as well as acid-base imbalances, all of which can lead to a coma, seizures, and death if left untreated. Now, unfortunately, when somebody enters into renal failure, more chronic renal failure, and the kidneys are really failing, you need to go through a dialysis until you can either obtain a kidney transplant. Now, you only need one kidney, actually, to maintain normal functions here. And dialysis can be used to treat the signs and symptoms of uremia. Hemodialysis, this is temporarily going to remove blood and pass it through a filter, reducing metabolic waste and excess fluid. It also normalizes electrolyte and acid-base balances. Peritoneal dialysis, this is dialysis fluid is placed into the peritoneal cavity and allowed to circulate for a set period of time to remove metabolic waste, excess fluids, and then eventually to restore electrolyte and acid-base balances. The Ras System and Hypertension. There are 3 classes of drugs that can act on the Ras system to reduce blood pressure. You have your ACE inhibitors, which are developed from snake venom, will block ACE, therefore inhibit the conversion of angiotensin 1 and 2, which will ultimately lead to you not being able to increase that blood pressure and decreasing it. Angiotensin receptor blockers will block receptors on the blood vessels and the proximal tubule cells. This prevents vasoconstriction and reabsorption of water and sodium. And then you also have your aldosterone antagonists. These block the effects of aldosterone on the distal tubule. They decrease reabsorption of sodium and water, and this leads to diuretic effects. Drugs may decrease GFR in patients with pre-existing renal diseases, and these particular patients must be monitored. And that will be it for recording number 2.